My name is Alexander Brucker. I recognize some of the faces here, and I say hello to those who I know, and I welcome those who I don't. I am a retinal specialist here at the University of Pennsylvania, the Scheie Institute. And the Scheie Institute has been around a long time, treating a lot of patients with a lot of eye diseases. So it's our pleasure to be able to come out tonight and speak to you and talk about the topic of choice. What are we talking about, by the way? Age-related macular degeneration. A very complicated topic, not easily understood. But before starting, I'm going to ask a few questions. Let me ask you, for those of you sitting in the room, to raise your hand and let me see those of you who have age-related macular degeneration. And for the caregivers and relatives, okay, good. Age-related macular degeneration is a very interesting disease, unfortunately very common now. As the population ages, we see more and more patients growing to older age and developing macular degeneration. And it is in fact age-related. So young people in general don't have age-related macular degeneration, and older patients do tend to get age-related macular degeneration. I'm not going to go over numbers and I'm not going to go over specifics with you. It's superfluous. For those of you who have the disease, it doesn't matter if you're 1 in 100 or the 99 out of 100 who get it. And for those of you who don't, hopefully you won't get it. But what I'm going to try to do this evening in the short period of time that we have together is give you some idea of what macular degeneration is and what we're doing for it today, what we hope to do for it in the future, and what you should expect from your doctors who take care of you or take care of your loved ones or those who you're caregivers for. Let me first start by saying that the macula is the central portion of your eye. It's a portion of the retina that we see with. So what is the retina? The retina is like wallpaper on a wall. The wallpaper is a neurologic tissue that carries impulses from the eye back to the brain. So the retina is like film on a camera, if you will. But it's also like wallpaper in that it's the lining on the back of the eye. And this wallpaper lines the back of the eye, and it has many different parts. For those of you sitting in front of me, let's just make believe that I'm in the back of the eye and you are outside the eye looking in. I'm going to try to use analogies and give you ways of thinking about the eye, and I hope you can understand them. Behind me is a screen. That's like the back of the eye. That's like the retina. And in the eye, it wraps around the whole inside of the eye. And in fact, the retina can become detached, and I'm sure many of you have heard of a retinal detachment. But all the way, this wallpaper that surrounds the whole inside of the eye, the macula is only behind me. It's only the central portion of your eye. And the macula also has different qualities to it. The different qualities are that when you focus with the macula, you see very sharply. But as you get away from the center of the eye, things become blurred. So for those of you who see well, when you look at me and look at my face may be perfectly in focus. But my shirt and my arms become less and less in focus. And as you look at me, the things to the side of the room aren't in focus at all, unless you look there. And the reason you look there is because the macula is the only part of the eye that puts things in perfectly good focus. And that's the reason that macular degeneration is so severe when it occurs in patients with age-related macular degeneration. When you get macular degeneration, it affects the central portion of your vision. So your side vision may be intact, but your central vision is lost. And let me give you a little example. I'd like you all to look just at my face, just at my head, and you see my hands. And my hands are moving. And I should be in perfectly good focus for those of you who can see. But my hands, which are in the movement, are the side vision. I'm going to give you a little idea of what it's like to have macular degeneration by asking you all to put your hand out in front of your face, put your thumb up, close one eye, and put your thumb right on my face. When you put your thumb on my face, you have a little blind spot. Slowly but surely bring your thumb back towards your face. Bring it back towards your eye. Keep it right on my face. All of a sudden, you lose my whole head. And all of a sudden, you'll lose my whole body. And that's called a scotoma, or a blind spot. It's a way of understanding what macular degeneration is all about. Because people with macular degeneration have this dark spot right in the center, or gray spot right in the center of their vision. Now, there are many people with macular degeneration that don't have age-related macular degeneration. There are younger people who have other forms of macular degeneration, such as Stargardt's disease, fundus flavimaculatus, and other types of diseases that cause loss of central vision. But tonight we're only talking about age-related macular degeneration. And most of the time we're talking about patients over the age of 55 or 60 who develop loss of vision that is of two kinds, a wet kind and a dry kind. But before talking about the wet kind or the dry kind, let me tell you what a common denominator is in all patients with age-related macular degeneration. All patients with age-related macular degeneration have little white dots in the back of their eye. And those little white dots are called drusen. Most of you nodded. You've heard the word drusen. Drusen are little white dots in the back of the eye which are precursors to macular degeneration. Lots of people have drusen. And the people who have the drusen can develop macular degeneration. All patients with macular degeneration, age-related macular degeneration, have drusen. But not all patients with drusen develop macular degeneration. So the first thing to understand is that if we see a patient with these little white dots, which we call drusen, we know that they are at risk for developing macular degeneration, age-related macular degeneration. And when we see that, we're always concerned that that person could develop macular degeneration. If you have large, soft drusen, because there are different kinds of drusen, if you have large, soft drusen, we use the term early macular degeneration. I happen not to like the term, because people come to me all the time and say, my doctor told me I have macular degeneration. Does that mean I'm going blind? And they may have one or two drusen in the back of their eye. And while it does put them at risk, it doesn't mean that everybody who has drusen are going to develop macular degeneration. But anybody who has drusen is considered to have early macular degeneration. And we watch them carefully, and we treat them. And we'll talk about treatment in just a few minutes. But again, all patients with macular degeneration, age-related macular degeneration, have these drusen. And then if they do develop macular degeneration, they develop one of two different kinds. One is the dry kind, and the other is the wet kind. Well, what is the dry kind? The dry kind is a little bit like grass on the field in the middle of the summer, and there's no water, and it dries out, and the grass dies. In macular degeneration, for some reason, in the central portion of vision, right in the macula, the cells start to dry out and die off. There's nothing we can do about it right now. They just die off. and that's called atrophy. Those cells just die, and that's the dry form of macular degeneration. It is the most common form of macular degeneration, of age-related macular degeneration. It also is very slow and insidious. It begins slowly, a little bit of fading of vision, people see a little haziness, and over a period of time, it worsens. Does it always worsen? Pretty much so. So people who have the dry form of macular degeneration usually do have progression. And visual loss can occur. People can lose vision. And people can become legally blind from dry form of macular degeneration. Now, we talk about blindness, and let me just add parenthetically, we talk about blindness. You can be blind, legally blind, which means you really can't see the eye chart very well. You have less than 20/200ths vision. I won't describe what that is, but most of you have heard the term. Most of you can develop that. You can lose vision, central vision, but that doesn't mean you're black blind. It doesn't mean you're not going to be able to see to get around, because you still have your peripheral vision. That's why they use the term legal blindness. That's as compared to somebody who has total blindness, sees nothing, everything is black, has no vision. So people with macular degeneration of the dry form can develop legal blindness. They can develop loss of central vision so that they have a dark spot in the center. They can't read the newspaper. They may not be able to see faces. They may not be able to see their check to write and sign signatures. They may not be able to see the letters on a deck of cards. That can occur in the patients with dry macular degeneration. It's a slow and insidious form of macular degeneration. But then there's the other form of macular degeneration, which is the wet form of macular degeneration, which everybody hears about and you read about in the newspaper. And that can occur overnight. You can be perfectly fine one day, and the next day you could have loss of vision. Because the wet form of macular degeneration means you have fluid in the back of your eye. And when you get fluid in the back of your eye, it's like getting a blister underneath wallpaper. You know how if you have a leak in the wallpaper, or you get a pocket of air or bubble under the wallpaper, all of a sudden you get this little blister? Well, you can imagine that if your vision requires the retina to be perfectly smooth and perfectly flat, and if you look out and your vision is perfectly normal, it means your retina is perfectly flat and perfectly smooth. But if you get fluid under the retina, it starts to get wavy. And if it gets wavy, it may mean that you have fluid under it, and now you've all of a sudden got a little bubble of fluid under the retina. That's the wet form of macular degeneration. And the wet form of macular degeneration can be fluid, or it can be blood, bleeding. If you have bleeding under the retina, that's pretty bad. Bleeding under the retina is not something that anybody wants to have, even in age-related macular degeneration, because the prognosis for eyes with bleeding is not real good. On the other hand, if you have fluid under the retina, which means that you have a little blood vessel that's leaking, just leaking a little fluid, the prognosis today is really pretty good. I'm going to talk to you about that in just a moment. So the wet form of macular degeneration means that in the back of the eye, as compared to the dry form where things dry out, in the wet form, something is leaking. I'll give you an analogy. I hope you can understand it. It works for me, and hopefully it'll work for you. If you're walking along a sidewalk and you have a weed growing up between the pieces of concrete or between bricks, and that little weed is growing up, that's what happens in macular degeneration, the wet form. We get blood vessels that grow up between the cells, and that blood vessel's just like a weed. And just like a weed grows out, all of a sudden it may flower, or whatever happens to a weed, maybe it's a dandelion, whatever happens. If it happens in the eye, those blood vessels that are growing up between the bricks, which are called pigment epithelial cells, when those blood vessels grow up, they can hemorrhage or they can leak, just like a leaky faucet. And when they leak, they flood the back of the eye. Another analogy is if you have a hose running right through your living room. It's okay if it's not leaking, but you put a little pinhole in that hose, and then all of a sudden, there collects a puddle of fluid in your living room. And that's just what happens in the eye. A blood vessel grows, which is an abnormal blood vessel. These blood vessels usually grow in eyes that have drusen. And this blood vessel grows, and it's going to do one of two things. It's either going to leak fluid, so you get a puddle of fluid, or it bleeds. And that's called the wet form of macular degeneration. In the past, what we used to do is we used to treat those little blood vessels by burning them up. We used to use the laser beam. Again, one of my analogies, and if you get bored by my analogies, I apologize. You remember when you were kids and you used to take a magnifying glass and you shine the light from the sun on a leaf and you burned a hole in the leaf? That's what the laser does. We shine the laser beam in the back of the eye, we find that little blood vessel growing up between the cells, and we burn it. And when you burn it, it goes it shrivels up and goes away. And the laser treatment works great. And in fact, I still use the laser treatment in some eyes. There's a problem though. Number one, the blood vessels can regrow. You can't get them all. It's like trying to get that weed. You cut the top of the weed off and it grows right back again. So cooking it doesn't always do it when we do the laser. And second, if we try to use the laser too close to the center of your vision, we burn it. And if you burn the center of vision, vision is gone and you can't get it back. And for that reason, we don't use the laser as much today as we did years ago. So what do we do now? Well, several years ago, somebody decided that maybe we could use a cold laser, which was called photodynamic therapy, PDT. And we would give patients an injection in their arm and give the patients an injection of a special dye, and that dye would circulate through the body, go into the eye, and then we would use the light laser to stimulate the vessels, and all of a sudden we were able to cook those vessels. And in the beginning, it looked like it was pretty effective. In the beginning, it looked like it was more effective than using the laser beam. But that was short-lived, because right after that, all of a sudden we realized that there was another way of treating it. And there was a drug called Macugen. And Macugen was an injection that we gave inside the eye, and its purpose was to shrivel up the vessels and make them go away. And everybody got very excited about the Macugen, and everybody was getting injections of Macugen. But that too was very short-lived. Number one, it didn't work very well. But number two, another drug was developed. And that drug was called Lucentis, or ranibizumab. And that drug is now the standard of care for patients with wet form of age-related macular degeneration. That drug is a drug which is injected directly into the eye and helps to make the blood vessels shrivel up. It's a pretty remarkable drug. It works fabulously. It really does. But we've come to learn a lot about ranibizumab, or Lucentis, over the years. We've come to learn that most patients aren't cured by the use of ranibizumab. Most of the patients respond well to ranibizumab, or Lucentis, and most of the patients do very nicely with ranibizumab. The problem is that if you stop giving it the disease tends to come back. The condition tends to come back. I guess a good analogy would be a patient who has diabetes. Give them their insulin, and they're doing great. If you take their insulin away, they get in trouble. Or a patient who is on heart medication. They do great while they're on their heart medication, but if they stop their heart medication, they get in trouble. So we don't cure these diseases. And with age-related macular degeneration, when we use Lucentis, we tend to have to give it over and over again. The standard of care is to give the injections once a month. And patients say, how long do you have to give it? I say, I don't know. The original studies looked at giving the injections once a month for 2 years. And most of the reports and most of the literature talks about giving the patients with wet form of macular degeneration repeated injections every 4 weeks for year after year. The literature talks about 2 years, 24 injections, 1 injection a month, 12 a year for 2 years. And then they report the results, which were magnificent, absolutely magnificent. So the drug really does work in most patients. Well, let me confuse the issue a little bit, because I'm telling you that there's a remarkable drug which really is a miracle drug. In my career, which is now turning out to be a long career, in my career, I can tell you that I never thought I would ever see anything like this drug. It is, in fact, a miracle drug. But all of a sudden, we realized that there was a sister drug that was very similar to it. And that sister drug is called Avastin, or bevacizumab. And that drug was developed for the use in colon cancer. And it's now being used in other forms of cancer. And it too causes blood vessels to shrivel up and go away. And if you make the blood vessels shrivel up and go away using Avastin, why would you need the Lucentis? Those are sister drugs. Well, there's been a lot of controversy about the two drugs, because one drug is probably around $76 an injection, and the other is $2,000 an injection. And you say, well, my God, that seems like a no-brainer. Well, one drug was tested. The Lucentis was tested and has been shown to be effective and safe, and it works very well. The other drug we've used off-label. Off-label means that we've given it for something that has never really been tested. In fact, it works great. And most of us use it on a regular basis when we need to. But nobody really knows which is the better drug. Nobody knows that the $76 drug is as effective or is as safe as the $2,000 drug. So there is, in fact, a study that is now going on to compare the two drugs. Ranibizumab is being compared to bevacizumab. Avastin is being compared to Lucentis. And that study, which is a 2-year study, will finish probably in February, March of this coming year, within the next 4 months or so. And then hopefully in the not too distant future, we're going to know if the two drugs, when used the same, is going to be proven to be as effective, or if one's going to be better than the other. That's the simple way of telling you about that study. That's called the CAT study. But that study is still underway. So right now, those two drugs are used interchangeably by many people for many different diseases, including age-related macular degeneration. But in reality, we don't know if they're the same, and we will know pretty much so within the next 6 months. But when you have these two drugs, you'd say to yourself, well, this is fabulous, but if they don't work and you have to give it for the rest of a patient's life, isn't there something better? Well, there are new drugs that are being developed, and those drugs are being tested today. One of them is called VEGF-TRAP, and that's coming to the end of its cycle of investigation. And one of the questions that's being asked is, maybe you don't have to give it every 4 weeks. Maybe you could give it every 6 weeks, or maybe every 8 weeks. If you give something every 6 weeks, basically you're giving it somewhere around 9 times a year, as compared to 12 times a year. Or if you give it every 8 weeks, you're really only giving it 6 times a year, compared to 12 times a year. And you have to understand that this is not simple. It's not simple for the patient, it's not simple for the doctor, and it's not simple for caregivers. You have to come into the office, you have to be examined, you have to be tested, then you have to be prepared, you have to be given the injection, and you know, no injection is without potential complication. Anytime any patient receives an injection of anything, you're sticking a needle through the skin or you're sticking a needle in the eye. And there's always a chance of a complication. And while the complications are very rare, they can occur. And we physicians don't take this lightly. We take the sterility very seriously. We take the fact that people have to take off work to come in to be injected, or family members have to take off work to come in and bring their family members in. We take this all seriously. So hopefully we will see the development of drugs that won't need to be given every month, but maybe every 6 weeks or 8 weeks or even 12 weeks. In fact, for the wet form of macular degeneration, we now talk about what's called treat and extend. What that means is we'll give a series of injections every 4 weeks until the wet form of macular degeneration dries up. The fluid goes away. And if the fluid goes away, we may give a few more injections, but then instead of giving injections every 4 weeks, we might say, let's spread it out to every 6 weeks. And we'll do that for a series of injections. And if the patient stays dry, not that they have dry macular degeneration, but if their wet macular degeneration stays dry, we may go to 8 weeks, and then we may go to 12 weeks. My personal experience is that most patients, the vast majority of patients, can't go any more than 12 weeks. And I have reached the point in my practice, in my career, that I now give patients injections almost always at 12 weeks. If they're dry, I give them what I call a booster shot. I want to keep them dry, because if I let them go to 16 weeks, my personal experience is somebody develops a small hemorrhage, somebody develops leakage, and then all of a sudden you're starting all over again. All of a sudden you're trying to get that hemorrhage to go away or get the fluid to dry up again. And in my practice, and in many of the practices that of my colleagues around the country, we in fact will give the injection at every 12 weeks. We'll evaluate the patient at 6 weeks. If they're dry, we leave them alone, bring them back at 12, check them again, give them an injection, bring them back at 6, make sure they're dry, bring them back at 12. Is it worth it, in my opinion, to be injected 4 times a year? Yes. I don't think anybody wants to lose their vision at any age, and our experience and my experience is that if you stop giving the injections, patients get into trouble. Let me back up a little bit and talk to you about 2 things. One is the evaluation of the patient with dry and wet macular degeneration. There are 2 tests that most of us do relatively routinely. One test is a dye injection that we give in the arm. It's called fluorescein angiography. Patient sits at a camera. We give them an injection in their arm. The circulating dye goes around into the eye, and we take pictures. It allows us to look at the circulation in the eye and to determine whether or not there are any blood vessels that are leaking inside the eye. It also lets us see not only the leaking blood vessels, but the dimensions, a 2-dimensional picture of where the leakage is. In my opinion, critically important numbers, critically important information for the evaluation and the prognosis of each individual patient. The second test that is done, which is done more routinely, usually done every month or every 6 weeks in most patients, is called an OCT, optical coherence tomography, OCT. And OCT is simply bouncing light off the back of your eye, and that light gives us a picture, and that picture shows us what the retina looks like. If the retina shows that there's fluid, we know that there's leakage. If the retina shows that there's no fluid, then we know that we've been able to dry out the patient. In the dry form of macular degeneration, we can see the area of what's called atrophy. We can actually see it with the OCT. In the wet form of macular degeneration, we can also see the accumulation of fluid, where the fluid is, and how much fluid is present. Over a period of time, if we give injections every month, all of a sudden we see that fluid dry up. If the fluid dries up and the macula becomes dry, not that you've now developed dry macular degeneration, you still have the wet form of macular degeneration, but it's just dry. Once it dries up, we might be able to back off the monthly injections, start to give it every 6 weeks or every 8 weeks or every 3 months. And we use the OCT as a guide. And intermittently, we will do the dye test, the fluorescein angiogram. Every 3 months, maybe every 6 months, everybody has their own way of practicing. But we use those two tests routinely. Unfortunately, and I apologize to those of you who are my patients sitting in the room, but unfortunately, those tests take a lot of time. And we all get backed up in the office for hours, because if you have a half a dozen patients waiting to get their OCTs, I have to wait for the OCT before I can do the injection. But it's a necessary evil, and it's something that is very, very helpful. So waiting for the pictures is a necessary problem, but the results and what it tells us is absolutely essential. In fact, the OCT, like ranibizumab or Lucentis, is actually a miracle. Nobody would have ever dreamed that we would have such an instrument 10 or 15 or 20 years ago. It is truly a remarkable feat of science. It's a little bit like an MRI or a CAT scan. It doesn't use the same techniques, but it's as remarkable as being able to look through a body and see tumors or growth or blood vessels in the body from outside. So OCT is very helpful, and fluorescein angiography, again, is extremely helpful. So these are the tests that we use for both the dry form of macular degeneration and the wet form of macular degeneration. But what are we doing to try to prevent this from happening? In fact, there have been a lot of studies and a lot of things that people have tried to do, but right now there really is one proven entity that works to try to reduce the risk of developing the wet form of macular degeneration. And that's the use of the AREDS formulation of vitamins on a regular basis. Patients with drusen, especially patients with large, soft drusen, should be taking the vitamin supplements if approved by their medical doctor. They should not take it on their own. Vitamin C, vitamin E, zinc, copper, and beta-carotene were the drugs that were studied, the vitamin supplements that were studied and shown to be effective in reducing the risk of developing the wet form of macular degeneration in patients with large soft drusen. There is no question that if you can tolerate it, if your doctor feels that you can take it, that these vitamins are worthwhile taking. Now, there has been some controversy about the use of beta-carotene. And it happens to be that there is a formulation which uses lutein in its place. It's perfectly okay to use that. You have to understand it was never tested, but it's felt that the lutein probably has the same effect as the beta-carotene, with probably less controversy. So there are the two formulations. There's the AREDS formulation with beta-carotene, and there's the AREDS formulation with lutein. It happens to be that there was a controversial study that came out of Canada that talked about the use of beta-carotene in smokers. And it was felt best that smokers should not take beta-carotene, and therefore the lutein formulation is often referred to as the smoker's formulation. But if any of you who are non-smokers want to take the lutein, it's perfectly okay. Those pills usually come in a small capsule, and you take 2 a day, 1 in the morning and 1 at night. If you want to take them both in the morning, it's fine. Or both in the evening. I don't know anybody who says that's no good. The main drug that has been used, and I get no financial reward, I get no money for this, is the formulation made by Bausch & Lomb called Preservision. But there are many other formulations out there, and as long as they're indicated as being the AREDS formulation, A-R-E-D-S, as long as it's in the formulation, the AREDS formulation, that's fine. Now, there are lots of formulations that have the AREDS formulation and a lot of other stuff, and that's probably perfectly fine too. Just as long as you have the right amount of the AREDS formulation, I would suggest to you that you make sure that you're taking an AREDS formulation. Now, is the AREDS formulation the only formulation? No, because again, nobody knows if that's the perfect formulation. That study was done a long time ago. And now there's a lot of other science and a lot of other information. And in fact, there is a new study being done called the AREDS 2. And many of my patients are in the AREDS 2 study. And the AREDS 2 study looks at multiple formulations of vitamin supplements to see which formulation, which concoction works best. And we don't know. So the AREDS study, the AREDS 2 study, is still ongoing, will probably be ongoing for a while before we come up with an answer as to which of these formulations is the best. It may be that the original was the best. It may be that one of the new formulations is the best. We don't know. But there is a study called the AREDS 2. It's closed. We have recruited everybody. You can't get into the study now. But that is, again, a vitamin formulation study. So what else are we doing for macular degeneration at this point? Well, right now we are looking at other drugs to try to prevent blood vessels from growing. Let me tell you that the growth of blood vessels is clearly a topic of great interest in many walks of life and in many disease entities. Growth of blood vessels is often referred to as angiogenesis. The growth of vessels, angiogenesis. And if you can block these blood vessels from growing, you can block a lot of bad things from happening. So an example are tumors, both benign tumors and malignant tumors, cancerous tumors. A big tumor needs blood vessels. It needs to be nourished. If you can block the blood vessels from growing into a tumor, you can stop the blood vessel, you can stop the tumor from growing. And this was in fact the reason that the first drug, which was the Avastin, was developed, because it's called an anti-VEGF, vascular endothelial growth factor drug. Anti-VEGF drugs are supposed to stop blood vessels from growing. Avastin is one of those. Lucentis is another one. And there are many others coming down the pike. So there are a lot of drugs being developed today that may be able to block angiogenesis, block blood vessels from growing, not only in the eye, but in other parts of the body. I'll give you an example. When we do corneal transplants, cornea is the surface of the eye. Blood vessels sometimes grow in as a form of rejection. And if the blood vessels grow in, those corneal transplants fail. So if you can give a drug, as a topical drug or otherwise, and it stops the blood vessels from growing in, you can prevent the blood vessels from growing and causing rejection of the transplant. So the blockage of blood vessels is really important. And in age-related macular degeneration, there's lots of research being done to try to block the blood vessels. Most of the research being done today in age-related macular degeneration has been focused on this acute form of macular degeneration, which is all of a sudden somebody wakes up and has a hemorrhage in the back of their eye, or a collection of fluid, the wet form of macular degeneration. But there's a lot of interest now in the dry form of macular degeneration. If we can prevent cells from dying, if we can prevent this little patch of dried grass from getting bigger and bigger, if we can prevent these cells from dying, we can preserve vision in the dry form of macular degeneration. And there's now a lot of attention being drawn to the dry form of macular degeneration. I believe, although I can't guarantee you, I believe that we will be one of the centers for a new study to look at dry macular degeneration, and we should be doing that within the next 6 months. Very fascinating concept. Dry macular degeneration prevented from getting worse. Again, a miracle if we can do it. But there's something else that's very, very important and very interesting that's being done. What happens if we give one of these drugs, but we give it in a new vehicle? We give it a different way. Instead of having to come in and give you an injection every 4 weeks, what if we could give you a pellet that we inject in the eye every 3 months or every 6 months? What if we could give you a drop that penetrates your eye and you can use it once a day? What if we can give you a new way of drug delivery? Drug delivery is one of the most sought after forms of research today in medicine. Think about it. Think about the person that takes a pill 4 times a day. What a pain in the neck. You got to remember to take it, breakfast, lunch, dinner, and when you go to sleep. What happens if the drug company can find a way of putting that pill that you take 4 times a day into a once-a-day pill? Compliance is better. The effects may be better. People won't miss their pills. They won't miss their medication. And if you can give everybody pills just once a day, the likelihood is that they'll be better off because they won't skip any, they won't miss any. That's called drug delivery. And if we can now put a drug inside something and then give it to the patient as a pellet or otherwise, we may be able to help a lot more patients because somebody coming from far away only has to come maybe once every 3 months or 6 months and doesn't have to worry about coming every 4 weeks for an injection. Or maybe they use the eye drops and prevent themselves from losing their vision. So drug delivery is another very interesting way of approaching age-related macular degeneration. Age-related macular degeneration occurs more frequently in older people than younger people. So people 55 years of age can develop macular degeneration, but it's not real common. Patients 90 years of age often have age-related macular degeneration. So as the population and baby boomers like myself all of a sudden start to age, the likelihood of seeing more and more patients with age-related macular degeneration goes up. And hopefully in the future, we're going to be able to find better ways of treating, more effective ways of treating, safe ways of treating, and be able to perhaps even not only treat those patients who have the disease, but also treat those patients who may get the disease, for example, patients with drusen. One question that was asked several years ago is, what happens if you can prevent drusen from developing? Isn't that an interesting question? Or another question was, what happens if you can make the drusen go away? So we, in fact, did a study, and that study was a laser for drusen study, where we took patients who had perfectly normal vision, and we did laser in their eyes because we thought that we could make the drusen go away. Bottom line, didn't work. Some patients, the drusen does go away. But we didn't find that we reduced the risk of developing the wet form of macular degeneration. And for that reason, the study had a negative result, meaning that people don't receive the laser treatment because it's not effective. That brings me to another issue, because we did a study, and gee whiz, the study didn't work. We did another issue, and that was a drug called thalidomide. Many of you have heard of thalidomide. And you know, those were the babies who wound up with no arms and no legs. And the thought process was that thalidomide caused the blood vessels of the appendages not to grow in these infants. And gee, if you could make the blood vessels not grow, let's use it in age-related macular degeneration, and maybe we could prevent blood vessels from growing in an adult. You don't have to worry about affecting their arms and legs. And as you know, this was a sleeping pill. So in fact, it was tried, and everybody wanted to get the thalidomide. And people were going and getting thalidomide from other countries where it was approved for other usages. And in fact, there were a lot of complications, really, really, really bad complications. So people were getting on the bandwagon to do studies, and it was better off that you didn't do it than you did do it. And there were other studies like interferon, where everybody was going to get interferon for age-related macular degeneration. And it turned out that the patients who got the interferon did worse than those who didn't get the interferon. So the patients who were in the study group didn't do so good. And the patients who got placebo or salt pills or artificial salt water, they did better. And why am I saying this to you? I'm saying this to you because many people come to me and say, well, I want to be in your study, but I want to get the drug. I want to be in the study, but I don't want to get the salt pill. I want to be in the study, but I really want to get the real stuff. Sometimes you're better off getting the placebo than you are the real stuff. If Sandy Brucker knew that the real stuff was better than the artificial stuff, I wouldn't do the study. Why would I subject you to an experiment and give you the artificial stuff if I thought that the real stuff worked? That wouldn't be right. But it's critically important for those of you who are interested in helping not only yourselves, but your children in the next generation, that when you hear about a study, you should try to get into it. We wouldn't be doing the study if we didn't think it worked. We wouldn't be doing the study if we thought we were going to harm anybody. And if we're legitimate, and if you're legitimate, and your thought processes are right, you got a chance of getting either the study drug or the placebo, and either you're going to do better or you're not going to do any worse than you would have normally done. So from my standpoint, the reason I make this pitch is because I want you to know that if you hear that the Scheie Institute, University of Pennsylvania, Department of Ophthalmology, is doing a study, that consider volunteering for it. Consider trying to get into it. Because not only may it help you, such as the Lucentis trial, God only knows how those patients did so well. Not only the Lucentis trial, but other trials where patients benefited. And not only will it benefit you, but it'll benefit the next generation coming up behind you. We need to understand these diseases. We need to find ways of treating these diseases. So this is what age-related macular degeneration is. It's a disease that causes the wet form and a dry form. The dry form, we're just trying to find ways of stopping the progression. The wet form, we have some wonderful ways of treating it, and we're finding new ways now. Hopefully, someday I'll be able to get up here and be able to say we have a way of preventing it, preventing drusen from developing, or prevent drusen from developing into wet form of macular degeneration. I have many, 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 many 35-year-old patients with a lot of big drusen. And it scares me to think that they may develop the wet form of macular degeneration or the dry form and lose vision. I hope that in my lifetime, I'm going to be able to say to them, I have something to treat you with so that you won't lose your vision when you hit 55, 65, 75, and 85. With that, I hope I was able to be informative to you. I hope you had an idea, get an idea of what we're all about and when we take care of our patients. And hopefully this has been helpful to you, and I appreciate you all coming out this evening. Thanks very much.
Thank you.